Good afternoon, everyone. This is Kate Wilcox with the Oregon Health Authority Maternal and Child Health Section in the Public Health Division. And welcome to our second offering of the Oregon Universally Offered Home Visiting Initiative Stakeholder Update webinar. We're really glad that you chose to join us and hear the latest on what's happening with this really exciting initiative. We have listed there our partners that are helping to lead this effort: the Oregon Health Authority, the Early Learning Division, the Department of Consumer and Business Services, and of course our partners, the Family Connects International. So we hope you will find the information that we share with you today helpful and helping you feel more grounded in the work. Now I have to click this. All right, so the purpose today is to provide all of you with the latest information on Oregon's Universally Offered Home Visiting Initiative. A lot of exciting things have been happening, and I think we are well on our way to moving this whole work forward. Our agenda will be, we're going to do some introductions and some housekeeping. In order to get everyone level set and kind of on the same page, we're going to do just a brief background and review of why universally offered home visiting is important in Oregon. Then we'll do an overview of the Family Connects model. What does it look like? What's it going to look like in Oregon? And then we will do some updates. So where are we now in this initiative? Then we will provide a few opportunities for involvement. For those of you that want to get more involved or just stay abreast, we'll have some different opportunities for that. And then lastly, we'll spend most of the time on questions. And so this really is an opportunity for you all to ask questions. We will be recording this webinar along with the answers to the questions. To that end, we're going to ask that you type your questions into the chat box, and then at the end, we will be reading them and providing answers so that it can all get recorded. And then we'll be posting the recording on our website. So your presenters today are Jordan Kennedy, our Oregon Health Authority Community Systems Manager here in the Maternal and Child Health Section, myself, Kate Wilcox, Maternal and Child Health Manager at OHA, and Ashley Alvord from Family Connects International. So we hope that this is helpful for everyone. So we'll start first with a brief background of why universally offered home visiting. And Jordan will take it away.
All right. So why universally offer home visiting? So as we know, the birth of a child is a big change for any family. And most families, as they're going through this transition, they welcome the support that can come with it. Safe and healthy environments during the early childhood forms the foundation for lifelong physical and mental well-being. So as you know, we talk about life course and talk about social determinants of health, that's where this comes in. It's also important to meet the families where they are. And providing services to all families is the route to community level change and system level impact. It's also cost effective investment in the long term for population health outcomes. So Oregon is well positioned for an initiative such as this. Firstly, we have high support from our high-level support from our governor, legislature, and our state agencies. We also have quite a breadth of and depth of home visiting across the state. So we have our evidence-based programs, Healthy Families Oregon, Early Head Start, Nurse Family Partnership, and then our other even homegrown programs such as Babies First. We also have Cocoon and Relief Nurseries and others. We also have an effective collaboration and partnership opportunity. So with our early learning hubs, our local public health, our health systems, community-based organizations, and our culturally specific organizations. The next thing is our data system. So as we begin to roll out our new data system, Theo, which is tracking home visiting effectiveness in Oregon, we expect that to also be able to help us make greater improvements on the system because the data that we collect will be richer. Right. And we're also well positioned due to some identified opportunities. So current screening efforts do not reach all Oregon families, and only about 20% of the families that are eligible for current programs are being served collectively by the home visiting system. Investments are not uniform across the state, so we could benefit from having more equitable investments in our communities, as they are all different and have different needs. And finally, just the opportunity to have a universal touch point or gateway, if you will, to connect to other needed services within the community. So it comes to our goals of universally offered home visiting. It's to create and strengthen community-level systems of care for families of newborns, offer support to all new parents in Oregon, and that's regardless of risk and insurance status, increase access to community services and supports, and promote collaboration and coordination across Oregon's early childhood and home visiting systems, and finally, improve health outcomes for families across the life course. Right. So in response to those goals, Oregon will be implementing our universally offered home visiting initiative using the Family Connects model. It is an evidence-based universal model that creates and or strengthens our local systems care and referral to support families with newborns. Evidence shows that it has a return on investment, so for every dollar that is put into the program, they have found a yield of $3.02. And savings for emergency health care costs. We have reduced ED visits, which were reduced by 50%. In the first year of life, as well as infants had 85% fewer hospital overnight stays in the first year of life. Families also reported 15% more connections to community resources within the previous 3 months. So from that, our key points with this initiative, so we're looking at doing a phased approach of implementation, so over 3 biennia. Family Connects will build on the current work in the community, so there's no need for reinventing the wheel. The funding mechanisms that will include targeted case management for Medicaid populations and the commercial health plans will also be covering their members as well. Family Connects will not replace any intensive home visiting model, but create a more cohesive system and laying the foundation for children beyond the age of 6 months and connecting them to those other services. And during this time, we'll also still be exploring other funding opportunities. And now, what does the Family Connects model look like?
Thank you, Jordan. And just a reminder to make sure if you have questions at all during this presentation, to go ahead and put them into the chat feature online, question feature, and we'll make sure that we stop and answer those at the end. So we're going to share just a bit about the history of the Family Connects program, which was initiated in Durham, North Carolina as a call to action from the local funders and stakeholders regarding child abuse and neglect. The initial program began as a partnership and continues as a partnership between the Center for Child and Family Health, the local nonprofit agency, the Duke Center for Child and Family Policy, and Durham County Administration, including county commissioners, public health, and child welfare. The early research and evaluation in Durham resulted in an evidence-based model that had proven results, both in being able to implement a program with a high degree of fidelity and quality, but also meeting families' needs. In our early research, we began to understand the universal vulnerability that families face when they welcome a new baby into their home. And by being able to provide this type of service to all, we were able to meet the individualized needs of the family, as well as support our community stakeholders in ensuring that the capacity they bring, the resources and supports they bring, were being connected with families who truly wanted and needed those services. Based on that early research, demand from other communities has led to the creation of a dissemination team that sits combined between the Center for Child and Family Health and Duke Center for Child and Family Policy, and serves to ensure that the model is implemented throughout parts of the country with fidelity, but in regard to and respect to local context and driven implementation factors. The program itself is a population health model with a systems building strategy and a nurse home visit at the center. So in Durham, we did complete 2 randomized controlled trials and have done 1 quasi-experimental design in Eastern North Carolina, the original Duke evaluation team doing those 3 studies. We are recognized by HRSA as a McVie evidence-based model and are actively participating in replication studies around the country as well as innovation opportunities. So we challenge ourselves for ongoing rigorous evaluation through our university connections, but really strive to ensure that in all of our communities we are creating a non-competitive and value-added focus to our work. As Jordan mentioned earlier, because we are very dependent in the short-term model of being able to connect families to longer-term supports that meet their needs, we need to ensure that those systems and supports remain in place. The model itself is actually built for all families, regardless of income or background. So there are no demographic requirements around income or any other targeted need to participate. As we said, we learned in our research that all families have some need for support. In fact, it was over 94% in our original randomized control trial and continues to be that today. So all families with newborns are offered the visit. It is voluntary, and again, because we're looking for factors around to support families and identify strengths and needs, we traditionally will be serving families about 3 weeks after the baby's birth. For families that have different birth outcomes through NICU, foster or adoptive families, or others, there is some flexibility in terms of the scheduling for the first home visit, but generally speaking, it's about 3 weeks after the baby's born. Nurses are provided by a registered nurse, and that is part of our evidence base. The protocol in the home visit, which we'll talk about briefly in just a second, does require the education and background of a registered nurse to do that, and so that is part of our evidence base. However, in our programs around the country, and we certainly expect to see here in Oregon, we would have active and intentional participation and coordination with other service providers in the community, and that would be based on community context and desire and capacity to do that. In general, we have been able to provide this service without any cost to the parents and the family. And so that does, as we pointed out, require multiple funding sources often to do that, and will be part of our exploration period here to ensure that we can maintain that as a core component of the model in Oregon. The main program components, which you see here, are community alignment, which is the foundation of our model. It is the active participation and staffed functional roles of programs, the program in each community to bring partners together to begin to understand both capacity and need in the community and where those are not matched to problem solve directly. That foundation upholds the home visit, again, a protocol-based home visit, nurse administered, family-led, protocol-based visit with follow-up as indicated by that clinical judgment of the nurse and family need, and then the data and monitoring that happen both within the visit and are shared with community partners allow for more data-driven decision-making that is responsive to the needs of families in the community. So the model is actually the artful integration of all 3 of these components, and each of them have functional roles and fidelity assessments that go with them. Families experience the model as a very short-term part of their parenting and support in the community. They will often, we work within each of our communities to ensure families are hearing the messaging that this is universally offered, that it is a voluntary program for families to participate in, and that they are likely to be visited in the hospital by a staff member prior to going home, and that member will explain the program and very briefly offer to schedule a visit. In communities where we do not have a birthing hospital available, families may be going into other areas, across state lines even, to participate, then we might use other natural resource connection points to invite families to participate, including the medical home for the family. The invitation is pretty brief. We're just letting families know that we're excited to welcome their new baby into our community and giving them the opportunity to have a free check-in with a nurse about 3 weeks after they go home. That check-in then, based on the family's desire to participate, will be scheduled at a mutually agreed upon time. And then the nurse will then follow up with the family, complete the appointment, which manages usually to be between about an hour and a half to 2 hours. It is protocol-based, and so as you see here, there are very particular assessments and screenings that are done by the nurse in the moment of the home visit. However, it is parent-led and parent-directed, and that we're going to meet the questions and the needs of the family that they come to the door with. We usually start with, how are you doing? And the nurse will get a lot of questions right away, and so we'll work directly with the parent to ease those concerns, those initial concerns, and then work our way through a standard assessment protocol. That does include an head-to-toe screening, medical screening for infant and for mom, as well as providing standard teaching and education around newborn care, child care, parent-child relationship, and management of infant crying. There are standard screening and assessment through questions and observation around home safety and risk assessment for family safety and community safety. We also do standard screening in the home around postpartum depression, interpersonal violence, and substance use and abuse. Based on those standard screenings, the nurse is then able to create an understanding of strength and needs for the family, and based on those individualized needs assessments, create an individualized connection plan to community resources. Based on that initial home visit, the nurse may and the family may choose to have follow-up. They need to do that to complete assessments or to ensure that those connections are solidly in place for the family. But in general, what that looks like in our model is that the nurses will visit with the family between 1 and 3 times. At the completion of that third visit and the finalization of their work with the family, the nurse will close the case, and then another staff member will ensure that those connections were, in fact, productive and meeting the needs of the family through a follow-up connection with that family about a month later. So we find out about the family's experience with our program and our service. Do they have any feedback for us to improve our work? But then also ensuring that for the connections that the family desired, were they able to actually be in contact with those services, and have they received the services they needed? It is an opportunity to ensure that we're hearing from the family's perspective what their experience has been. All of that work sits on top of community alignment domains, which are, again, active staffed activities within each program. There are multiple activities for each of these spaces on the wheel here that you see, and they're holding together opportunities for sharing data and information both internal to program operations, with community partners, and with the community at large. And so here in Oregon, this is the space that will begin our work together, is ensuring that we understand how to create best practice and strategies to achieve best practice in each of these areas in the communities that have chosen to embark on this work. Each of our programs also, as we talked about, collects data. That data is collected with parent consent and can be retracted, any pieces of that. So parents are in control of how their information is used. It's a voluntary program, and we're not providing individualized reporting to anyone without the parent knowing that that's happening. However, generally speaking, we are able to get aggregate data information to ensure both program quality and integrity to the model, and for communities to be able to become better equipped to understand the needs that our young families have and the current community capacity to meet those needs and where there might be growth edges for that. So we'll, again, be working with each of these communities in Oregon and otherwise to ensure that we have best practice around the use of that data, but that all of the data that's collected is managed and handled with utmost care around security and privacy. Particularly, our program is able to look at strengths and needs for families in these 12 domains. Ultimately, all families will have a risk stratification score, an understanding from the nurse's perspective about their time with the family, their observation, their conversation with the family, and the standard screening tools that are employed in the home visit, allows them to be able to rate a family's strengths and needs around these factors. Particularly, just so you guys know, it's a very straightforward rating system, so it's easily used in an aggregate way. For families who don't have additional needs, where they may be very well positioned around these factors, they would be scored as a 1. A 2 would indicate that the nurse and his or her work with the family could meet the needs, but that there were additional needs for support around that particular factor. If a family needs longer-term support, such as other home visiting programs, WIC, child care planning, and job training, there's an opportunity to indicate that those resources were identified, that the referral was made for the family, and that the family was open to that referral, and that would be a 3 on their matrix. If the family is not open to referral, the nurse is able to document the referral was attempted in that area and what that is, and then there's the opportunity to follow up the family at that follow-up call to see if they're interested at that point in time in that referral. For families who may have emergent needs in any of these factors, then they would be scored a 4. And those do happen, and it's one of the main reasons to ensure that we have a nurse in the home checking in, particularly on medical and mental health needs for families at that point in time. These will probably feel very familiar to all of you on the phone. You know, we are working with families who have lots of needs, and we have an opportunity to connect them to lots of different types of community resources. I will also note that we do have a holistic approach, and so if there are other members of the family that have needs, there is a 13th factor that's not on this slide that would have the nurse being able to document that observation, that assessment, and any community connections that they're making for the family. We also are able to document if there are general community connections that are not related to risk, but are just good information to have, such as a lot of our communities around the country have Dolly Parton Imagination Libraries, or they may have other locally driven parent support programs that are just good information for families to have. So we're able to document that, and then ultimately be able to talk specifically about what referrals were made to what specific programs, parents' interaction with those programs, and their response to that referral. Okay, I'll pass it back to you.
All right. Thank you. And while we're on this page with this lovely family, just another reminder that if you have questions, feel free to type them into the chat box, and we will answer the questions at the end after we're finished with this final segment. Okay, so now where are we in terms of Oregon and what's been happening? Let's start first, a lot has been happening with the legislative session. Senate Bill 526 is the bill that passed this legislative session under the championship of Senator Steiner Hayward. You may know that she is a family physician by training, and she has stated very publicly that one of the reasons she got into the legislature was to help institute changes like this, where we can really move upstream and work with families so that we can change the trajectory of many families in a more positive, healthy way, and normalize that it's okay to get help, and all families need support from time to time. So the goal of Senate Bill 526 is to help families give their children a healthier start in life. Oregon is the first state in the nation to offer universally offered home visiting program, or home visiting for newborns and their families under a statute. So this is, a lot of eyes are looking at this statute and wondering, how did we do that? Well, we have some great champions, as Jordan was mentioning earlier. So that is sort of a hallmark for this work. This, the Senate bill passed kind of in June. It was before Sine Die, and it directs the Oregon Health Authority to design and implement a voluntary statewide home visiting program for families with newborns up to 6 months of age, and that includes families with adopted or foster newborns. The other part of it is it includes a requirement that the commercial health plans provide this benefit for their members as well, and that's a means of getting to the universality of this model and recognizing that truly all families need some supports at this vulnerable time. So that's a really exciting piece of work that happened, and yeah. The other piece that joins this is the financing for this bill. This bill did not have a fiscal attached to it. Rather, the fiscal support came through the Oregon Health Authority budget. The budget includes a $4.69 million line item for the 1921 biennium. And this funding will be used to design and implement the Universally Offered Home Visiting Initiative. So the way the budget is designed is in sort of three buckets. One bucket is to support some state-level infrastructure to be able to design, implement, and sustain the program. The second bucket is contracts. So we need to contract for some evaluation work, to create the data systems to be able to transfer this data. And of course, working with our Family Connects partners, we need to contract with them for their time. And I will say this is one of the really exciting parts of this whole initiative is oftentimes we are given funding and told, go do it. And with this time around, with Family Connects by our side, we are getting a lot of support, technical assistance, on the ground partnership and guidance from the Family Connects International people, truly over the next 6 years and beyond. So it's pretty exciting, and it feels very much supported. The third bucket are resources going to the community level. So at the community level, there are two parts to this. One, the Oregon Health Authority has the authority to implement the Medicaid program. As we know that half of the births in the state, approximately, are Medicaid supported. So within that community level work, or part of the budget, is a general fund that will go to support offering this service to the Medicaid population. With Medicaid, we have to put up a state general fund match, and we can draw down federal dollars to leverage those general funds to provide those services. So a lot of the community level financing will be to that. We also will have some small resources that we can apply to and provide to the communities as they go through this initial year-long process of planning and creating that local system of care that will be the foundation for the home visiting and the connection of the families to those services. The preparation support includes resources that will go to the community alignment process, as well as to prepare for the service delivery. So again, on the bullets here, we're going to be offering the service to the Oregon Health Plan members, and this is the first of a 3 biennial rollout, after which we anticipate all communities in Oregon will have this service available to them. So we're starting slow in this first biennium, and then we'll learn lots of lessons. We'll gain some momentum in the second, and by the end of the third, we hope to have this all rolled out. Okay, we have received, fortunately, through some partnerships, some initial support so that we could actually get a jump start on this prior to some of these other pieces being in place. The Early Learning Division provided some initial support through their federal preschool development grant. And these funds allowed the Oregon Health Authority to contract with Family Connects International to provide the required technical assistance and support so we could begin designing the program for Oregon and get a little jump start. It also is helping to provide the technical support and assistance with Family Connects to those local communities as they begin their community alignment process this coming year. All right, we have done some public engagement work, and we know that there is a lot more to happen. It is really our intent and desire to be very forthcoming and transparent with all the activities that are happening, and be sure that people have the latest information. We began some of this public engagement back in March. We had a stakeholder planning kickoff meeting on March 15th. We are following that up with today's update webinars. And then we are planning to have quarterly update webinars as we move through this process. And we want this to be an opportunity with anyone who has any interest in tracking and keeping up to date to be able to join these webinars. We also have established a steering committee. The steering committee is currently at, I think, 45. There are a lot of different partners who are interested and are key to helping us design and make decisions about this initiative. So our current steering committee has state and local partners, local public health, local early learning hubs, state level agencies. We've got the commercial health plans participating. We have tribes participating, community-based programs participating, our Medicaid partners, and just a whole lot more that I know I'm forgetting. But it's a very broad and rich group, and we need all those voices at the table in order to be able to design and drive this initiative. It is co-chaired by the Oregon Health Authority in the Early Learning Division. We've had 2 meetings so far, one on April 29th and one on June 19th, and we will continue to have those meetings monthly in an ongoing way. And then we anticipate there'll be some unanticipated work groups that are needed. We aren't sure quite yet what those are going to be, but as we identify extra work that we need to have happen, and we would like to have input from our community partners, we will send out announcements about that. We want to make sure that the work that happens there is of benefit, and we don't want to have work groups just to have work groups, but we really want them to be productive and contributing to the effort. So as those are identified, we will definitely be sending out notices. Okay, now this is a part that's pretty exciting. Even prior to the signing of the bill, or I guess it hasn't quite been signed yet, the governor has yet to do that, but the passing of the bill and the budget being finalized, we put out a call to communities to see what the level of interest was to being part of a cohort called the Early Adopter Cohort. We wanted to get things rolling so that when these final pieces were in place, we could get going and really jumpstart this initiative. So the purpose of this early adoption phase is really to learn as much as we can about the implementation process, what works, what doesn't work, what are some lessons learned, because we want to take that learning and then apply it to subsequent cohorts so that we can create as smooth an implementation process as possible. So we created a letter of intent process to solicit interest from various communities. We limited the submissions or the applicants to the early learning hubs and local public health authorities. And we did this on purpose for this phase because we want to do as much learning as we can. These two groups, the hubs and the local public health, have a lot of experience and expertise and are really charged with a lot of that creation of the local system of care. And so it seemed appropriate to start with these two entities as we're in this learning phase. We were thinking that we would be able to move forward with 5 to 6 communities as a cohort to be able to provide or to do the learning. We received 8 letters of intent, which was quite exciting. And we realized the limiting factor here is really Family Connect's ability to be able to provide the needed technical assistance and support for these communities as they go through the year-long planning process. So we asked our partners at Family Connect, what do you think about 8 communities? And they thought about it, and we looked at where they were, and they said, yeah, we can do this. So we took those recommendations to the steering committee, and we talked about all the communities, what are the strengths, what are the opportunities, Do we have good geographical representation? Do we have lots of other types of diversity that we're looking for, especially during this early adoption and the learning process? And the steering committee recommended back to the Oregon Health Authority that we invite all 8 early adoption communities to join the cohort. So it is a diverse group, and we will share with you who they are. The early adoption communities are Clatsop County Public Health, Lane County Public Health, Washington County Public Health, the Early Learning Hub of Lynn, Benton, Lincoln, the Four Rivers Early Learning Hub, which includes Hood River, Wasco, Sherman, Gillum, and Wheeler counties, Eastern Oregon Early Learning Hub, which includes Baker and Malheur counties, the Early Learning Hub of Central Oregon, Deschutes, Jefferson, and Crook counties, and the Marion and Polk Early Learning Hub. So these entities are what we call the applicant or the lead agency, but there was a requirement that they partner with their other sister agency. So if the applicant was an early learning hub, they needed to partner with the local health department, local public health. If the applicant was a local public health authority, they needed to partner with their early learning hub, because we want to make sure that connection is there and the collaboration starts, because that really will be the heart of the community alignment process. I want to show you what that looks like on a map. You know, if that picture speaks 1,000 words, you can kind of see where those counties are and how we've really got some nice geographical representation. We've got coast, we've got Central Oregon, we've got Eastern Oregon, we have urban, we've got rural, we've got frontier. The Central Oregon Early Learning Hub is also partnering with the Warm Springs tribe. So we've got some tribal engagement, although we will be looking for more in subsequent cohorts. So we were pretty excited to see this group. And just so you know, we had our kickoff meeting with the early adoption communities yesterday. It was an in-person meeting here in Portland. And I think by the end of the day, everyone was pretty excited about what's going to be happening over these next couple months, and the work that's going to need to happen as we lead up to service delivery. We anticipate service delivery will start July 2020 on average. Some of the communities may be able to work through their community alignment process more quickly. Others, it may take longer than a year, but on average, we're looking at service delivery to start about a year from now in these communities. All right, so what are some of our next steps? As we were just talking about, we're going to launch these early adopter communities and the work that they're going to do in terms of the community alignment work. At the state level, we're going to be hiring for the state level infrastructure. We have 3 FTE over 4 people. We'll be hiring a public health nurse consultant that can help with the program coordination as well as the training and working with the programmatic side of this. We will be hiring an operations and policy analyst who will specialize in helping us collaborate and coordinate with the commercial health plan world, how to set up those mechanisms for collaboration and billing and all of that. So we're pretty excited about that. And we'll also be working very closely with our partners at the Department of Business and Consumer Services, since they are the regulatory body over the commercial health plans. And so that really is going to be some exciting new and innovative work. We will also be hiring a half-time administrative support and a half-time research analyst to help us with the data. This fall, we will be developing and filing rules per the statute. We hope to have those rules filed by January, if possible. Per our usual process with rulemaking, we will have a rule advisory committee, and that will be an opportunity for people to engage. We will be launching our communication plan, including our website. We do have a website up and running. It's pretty static, pretty basic, and we want to get that to be a little bit more robust and informative, and a place where you can go at any time and be caught up to speed with what's happening. We will also be developing and implementing our project evaluation. This will be under the leadership of the Family Connects International folks and their connection with Duke University. We want to make sure that what we're doing actually is providing, is really reaching the outcomes that we anticipate, and so that evaluation component is very important to us. And as I talked about before, we'll set up committees and work groups as needed as we find that work pops up and we need some support. All right, what does the project timeline look like? This right here is a very high level, 4 biennium timeline. The 17-19 biennium shows the work that we've been starting with our initiations, starting to collaborate with Family Connects, the identification of our early adopter cohort. The 1921 biennium is called our phase 1. So in that, we'll be rolling out the initiative to our early adopter community as well as the first cohort. Then we'll roll out additional cohorts annually throughout the 21 and 23 biennium and ending up then finally in the 23-25 biennium. And by the end of that, we anticipate all communities in Oregon will be offering this service. Here's how it looks to unfold currently in this biennium, the 1921 biennium. It's divided, as you can see by the orange and the green bar on the side, by the early adopters and cohort 1. And that gives a little bit more granularity. You can see that we've gone through the selection process. We started that end of April. We've selected the cohort in June. And we will be starting, we've had our kickoff meeting, and so we're starting this year-long community planning and preparation phase. Next March, we'll be moving into the preparation for the actual service delivery with anticipation of starting to see families and offer the service to families next July, with a full rollout by the end of December in those communities. So we know that it takes a little bit to ramp up. And so we anticipate that by beginning of January 2021, those families will be offered this service. Cohort 1 will be a repeat of that same process, but we'll be identifying who's in that next cohort next spring with an anticipation of service delivery happening around March 2021. And again, rolling that through. So that's how the cycle will go as we keep bringing on new cohorts. Another way to look at it, for those that, like myself, I appreciate seeing Gantt charts and seeing the timeline in this fashion. So you can see how the two cohorts overlap a little bit in terms of their different stages of implementation. All right, so now we want to share just a couple of thoughts about opportunities for involvement. Like I talked about earlier, we will be having a Rules Advisory Committee this fall as we prepare and implement the rules that will be accompanying this statute, Senate Bill 526. If you don't serve on the Rules Advisory Committee, there will also be opportunities for public comment, which is our typical process in state government whenever we do rules. So there'll be communications about that coming out. We will have these stakeholder update webinars quarterly, and we hope that you will participate or join in so you can get the latest and greatest. And as I've talked about, we will have some high-level state planning work groups as the needs arise. And so again, we will put out word as we identify what we might need. But perhaps the place where you can contribute and participate best is actually at the community level. So where your communities are touching those that are going through the community alignment process, we really encourage you to engage with those communities because we are going to need all hands on deck at that level to identify where are the assets, where are the opportunities, and how can we leverage each other to build a sustainable system of care at the local level. So we encourage you to get involved there, and we can help facilitate connecting you with the local conveners of that work. All right. So now I think we're going to turn to the question portion of our webinar. And again, we encourage you to please type in any questions that you have. And Derek Patterson, who is here with us as our very skilled and adept support on this webinar, is going to share with us the questions that you've put in so far.
All right, thank you. So we've got some great questions here. The first one is, can you please go into more detail on the funding of this initiative, particularly from the health plan viewpoint?
That's a really good question. From the health plan viewpoint, we haven't really embarked yet on that process. We have, Senator Steiner Hayward has convened the commercial health plans to talk about the initiative and to help them start to dive into what it would look like for them. We will be engaging with them with the support of the Department of Business and Consumer Services, I think DCB, Consumer and Business Services, sorry. The letters flow off my tongue faster. And of course, our state level support capacity will be working with health plans. So I think the vision is that the health plans would provide this benefit for their members at no cost, and then how the services are rolled out will be identified at the local level, be it public health nurses, hospital nurses, community nurses. We're still looking at what that will be like, but we are very fortunate to have some of the health plans at the table with us.
Thank you. We've got a model question for Ashley. What percentage of families accept the invitation for a home visit or check-in?
And across the country, the invitation acceptance rate is about 80 to 85% on average. So it is a very well accepted program. Following that further, we look for about an 80% completion rate and how we can create operational process and procedure and supports to encourage that level of reach to the birth population. For certification, we look for a minimum of 60% reach. We'd like to see closer to 70% at the end of that year, and that is usually about a 12-month certification process to achieve that.
Thank you. The question, in North Carolina, have you seen any significant changes in acceptance rate of home visits by immigrant and refugee communities given the current political climate?
It's a really excellent question. Thankfully, most of our programs in North Carolina pre-existed for many years prior to the changes in federal policy. And we have trusted community partners working with multitude of stakeholders and families across the continuum through around documentation status or otherwise. So we have not seen any real significant drop-off in acceptance or participation in North Carolina. However, we are watching that very closely. To be clear, we do not collect nor report documentation status information in our program, and so we would be looking for ways to ensure procedurally that we can be truly a service to all families, and working with core stakeholders and trusted voices in community to ensure that we are, in fact, creating that safe space for families to say yes.
Thank you. Is Oregon planning for data entry via THEO for universally offered home visiting?
Okay, we can talk a bit about this. This is part of the planning process this year. Family Connect does have a wealth of data required to be collected and reported, not just for certification, but for use at the community level. We have thankfully moved into a platform that allows some interoperability, and there's some discussions with OHA around how to make that the best opportunity for communities to have the information they need at their fingertips across their home visiting service, and whether that, whatever that looks like, would reduce or eliminate duplicate data entry for our teams on the ground. We have some flexibility as a model to allow for data to flow from one site to the other, from one data system to the other. And so we're looking for opportunities to create efficiency without reducing the ability to make decisions with the data that's available. Mm-hmm. Do you want to add anything?
Yeah, and our vision is that Family Connects would be part of the CO data system, along with the other home visiting programs that have rooms in the CO house. And so I do think the opportunities that we have is that the CO database is built so that we can create those interoperabilities with other data systems. So the fact that Family Connects has their own data system, we look that is also open to interoperability. We do see that we'll be able to figure that out one way or another and create those efficiencies.
Okay. Are the slides for this webinar going to be available?
Yes. So actually, you can see right there on the screen the website. Now, I will say that this URL link is a shortened version of what the big link is, and we just got it today. So if it doesn't work, keep trying. It should work within the next day or two. That is where we're going to be posting the recording and the slides for this webinar. In addition, while we're looking at that slide, you also see an email address there. That's if you have questions or think of comments or thoughts or anything you'd like to share with us, that is the email address that you use, rather than any one of our individual email addresses, because we want to make sure that if someone's on vacation or out of the office, that we don't lose the timeliness of being able to respond to you.
Will there be new targeted case management rules specifically for universally offered home visiting, as it is a short-term program versus a targeted case management plan with typically ongoing visits?
Very good question. Actually, this model very much aligns with how targeted case management works from the federal level. Targeted case management, just for a little primer, is really intended for to do some screenings and assessments and make a referral and do that case management work. That directly aligns with what Family Connects is. Family Connects, the nurse does screenings, does assessments, makes those referrals, and then later, as Ashley described, there is a follow-up call to make sure that those referrals with the family to see how that referral went. So it is a closed loop system. So the only change that we are going to be needing to make is adding a new target audience, if you will, to our state plan amendment on this nurse home visiting state plan amendment that we have. And the new target audience is infants, Medicaid eligible infants, which is a subset of the Medicaid population.
Thank you. Got a couple more questions. Can you repeat the vision for CCOs in this program?
That's a great one. So we welcome CCO participation in the community alignment program, part of the planning. CCOs are critical partners at the community level, and their voice is very important as we design and implement this program. Because of where we are currently in the CCO 2.0, the contracting and all of that, the timing is not quite right to actually have this folded into the CCO contract. And so that's why we're using our current mechanism of targeted case management, which is carved out from the managed care program, to provide these services. But it's critical that there be close collaboration between the CCOs and the service providers, especially for the Medicaid population, but also just as part of being part of that system of care at the local level. Down the road, we'll see how this rolls out. I think one of the first visions is let's get this stood up and available in all the communities, and then we can maybe start working on universally offered home visiting 2.0 and see how we want to create more efficiencies and maybe make some changes in terms of how the CCOs engage with this at that time.
Excellent, thank you. You have outlined funding in FTE for OHA to administer and oversee this program. What is available for LPHAs to ramp up service, billing, management, and administrative capacity to implement the program? In addition to public health nurses and community health workers, this requires commitment to LPHA's leadership and organizational foundational capability.
From the model perspective, one of the key areas of planning includes the appropriate staffing model and implementation model that includes active participation of our LPHA partners. So what I can say is that in each of the communities that's moved into the early adopter phase, there will be an implementation plan with associated budget, staffing models that we would be presenting back to OHA to make sure that we can have that first and foremost in our mind about how to create the space and the opportunity to do this model as an evidence-based model. And we know that those pieces are critically important. I think that information then helps to shape the rulemaking and the opportunities OHA has for looking at funding. So I'm just looking at Kate, make sure that.
Yeah, and I do feel that one of the advantages of this, taking the time for the community alignment process, is that by having all the partners at the table, you can really see what resources and assets there are at the community level and be able to leverage across each other. This is creating a system of care. This is public health modernization for the maternal and child health population. And so I think it's looking at it more from that perspective. There will never be enough money to provide all of the supports for one organization to implement this, and that's not the vision or the goal of this model. This model really is about community assets coming together, partners coming together, and figuring out what works best and how does it work best in that community, not as a single organization who has the burden of doing this solely on their own shoulders.
I think I'd like to add just to that, I mean, part of the reason we have the planning process is our intentionality in being non-duplicative, supportive, and collaborative. And that means really leveraging the work that's already happening in communities to understand how this service complements that and what the marginal investment needs to be to do the work. It's not about replacing, it's not about duplicating, and we should be building a process that is supporting and actually elevating all of those services into some sustainability. So that is the goal and the vision. I think that as you are all sitting there thinking, the devil is in the details, and we will absolutely have more actionable data as we enter the planning period to make those decisions.
Thank you. Our next question, why did you drop the word nurse from UOHV, the acronym?
Oh, well, that's a good question. Actually, it was originally stated as universal home visiting, and we got some misunderstanding about that. And there was a thought that that meant it was mandated, that all families must have it. So that's when we added the word offered. So it's a universally offered home visiting. In the statute, it does say universally offered nurse home visiting. It's something we can add in. It adds yet another word, but that will be clear. It is clear in the statute and would be clear in the rulemaking too.
Thank you. What structures are in place to ensure service is delivered in a culturally appropriate and responsive manner?
So the community alignment structure is in place from our model's perspective to ensure we are culturally appropriate, humble, and working with community to develop those structures and supports. It is not a one-size-fits-all opportunity for that, and so each of our communities around the country is quite different in how, what needs they have, who they serve, and how to best meet those. And so that will be a key feature of the community alignment. Ensuring that we are working with, not on, communities across the state.
Okay. Those are all the questions that we have.
That's all the questions so far. We wanted to give you all a little bit more time if something sparked in your head in terms of a question. Once again, I will reiterate on the slide, if you think of more questions after this webinar or just want to share thoughts, comments, ponderings, please email us at the oregon.uohv@state.or.us, and we will be checking that email box every day. So our goal is to be able to be responsive in a timely fashion with questions and thoughts and considerations. We also have there the website link healthoregon.org/UOHV. Again, it may not be working quite yet, but give us a day or two. You can keep checking back, and that's where we will be posting this webinar. There are also some other links to different other presentations that you're welcome to take a look at. I'm not sure if it has a link to your website yet or not, but also feel free to Google Family Connects International, and there's a wealth of information. You can also see where this work is happening in other parts of the country. An interesting point is that the city of Chicago is trying to roll this out universally across that city. That city has the same number of births as our entire state. So there are some analogies in terms of the number of births served, but clearly there are very different contexts there. The state of Texas has quite a few sites, and we've got some sites that are Family Connects, you all have some states that are pondering and kind of in a contemplative stage of whether they're going to implement or not. So it is very exciting. It's not just in North Carolina anymore.
Yeah. And again, you can reach out through, if you have a question specific to the model, feel free to email the team here at OHA, and they can be in contact with us directly as well.
Mm-hmm. Are there any other questions that have popped up?
There are no other additional questions.
Okay. Well, thank you very much for your participation and joining the call. And we look forward to having these calls again next quarter, so that we can keep everyone abreast of what's happening. And with that, hope you have a good rest of your day. Thank you for participating.
Thank you very much.
So we've got a lot of great questions. Our first one is, how do you reach people? Through the birthing hospital? And are visits actually scheduled, or is it a drop-in situation?
So those are great questions. Most of the time we are scheduling visits directly at the hospital prior to discharge after delivery. However, for communities that may not have a birthing hospital, sometimes that invitation is made by phone or through the pediatric office directly. But these are scheduled appointments, and so it is not a drop-in service.
Okay. Thank you.
Sure.
One of our other questions is also about the model. Can families access these visits if they are already receiving longer-term home visiting services prior to the birth of their baby?
Most of the time the answer is yes, but the community will make a decision about how they would like to handle families who are prenatally enrolled in longer-term home visiting programs. That's part of the planning process in each of the communities, to understand the number of families that are engaged and the value added of another nurse or another home visitor working with the family. It is not a requirement of the model that if a family is enrolled prenatally, that they also receive a Family Connect service. So it would be the community decision. In a lot of cases, they're well served in those programs, they're pretty well connected, and the value add would be limited. So a lot of times communities decide to not provide the Family Connect service to those programs, to those service providers.
And then I just have a clarifying question for to go off of that. For the, they were talking about families who receive services prior to the birth. What if those services are for another child? That family is still eligible for?
Absolutely, absolutely. So if they're enrolled for another child in the home, for early intervention services or other services, the birth of any new baby would allow the family to be offered the home visit, and it would be the family's desire, and also from the community perspective, ensuring that families are getting what they need at the time they need it, really no more, no less. And so, but absolutely, if they're enrolled in other services, that would not mean that they're not eligible to receive.
Thank you.
Sure.
What is the plan to provide skilled lactation support? A visit at 3 weeks postpartum leaves a large gap of vulnerability for breastfeeding failure. I see a need for work group dedicated to integrating skilled lactation support by IBCLCs.
Sure. So most of our programs around the country have at least one IBCLC embedded in their Family Connects nursing team. All nurses will have some professional skill around lactation support. The way that the model handles that is that while the model's call to action was around reducing child abuse and neglect,
and supporting families to be connected with longer-term supports in the community, we recognize that lactation support is something that we can provide, particularly because our nurses have the ability to go to the home with the family. And so when asked, either by the provider or the family, we accommodate an earlier visit specifically for lactation or weight checks, or blood pressure checks for the mom or infant, any kind of physical assessment checks that are done in a shorter time. And then the nurse would go back to complete the full integrated home visit under the model at the 3-week period or a little bit beyond. So we do accommodate earlier visits for families that have those needs, and work with community partners to ensure that if those needs arise, that they know how to access the service through Family Connects.
Thank you.
Sure.
We'll switch tracks and give Ashley a break for just a moment. Okay, we have a housekeeping question. Is the presentation available to download, or will it be sent to participants?
We can absolutely send it to participants. We do have a web page that's pretty bare bones, and we will be posting it on that as well. So there'll be a couple of ways of being able to access them.
Thank you. Do you have a sense of how this bill will impact the nursing workforce? Traditionally, there are fewer public health nurses than hospital nurses. Will nursing schools be enlisted to develop a more robust public health nursing pool?
Yeah, this is a great question, and one we get a lot, and one that we've been grappling with as well. The public health nurse workforce is really specialized in how to effectively go into homes and work with families from a strength-based foundation. And that's a skill we want to assure is very much present in this model as well. With that said, there are a lot of nurses out there, hospital nurses, community-based nurses, public health nurses, that can very equally, with training and assurance that they are doing the model to fidelity, be able to provide this service. So I think that's one of the opportunities we're going to see as the commercial health plans come on board and the hospital system is engaged. Where are those nurses, and how can we best utilize the workforce that we've got? Another point that I'm always want to make sure that we know is that unlike some of the nurse home visiting models, this model does not require a bachelor's level preparation. So it requires a registered nurse license. So that opens up some opportunities, especially with some of our community colleges that have nursing programs. Are there community leaders and potential nurses in our communities that could get a 2-year degree and come back and provide this service within their community? I think we've got lots of different kinds of opportunities that we want to explore. And in some ways trying to build the cultural responsiveness and cultural specificity, as well as language depth and breadth of the nursing workforce, I think are some opportunities that we can, we're really excited about exploring.
Thank you. Will families be referred to longer-term home visiting programs if they're identified as needing additional support through universally offered home visiting?
Yes, absolutely. Our key partners in all of our communities around the country include the long-term home visiting programs, and working collaboratively is our goal in each of those communities. So ensuring families are aware of those services, understand what it would mean to enroll in those services, and are matched to the programs in their community that best are positioned to meet their needs and help them to succeed as parents.
Thank you. You mentioned additional resources needed in the future as the model is expanded to new geographic areas. Is this an ask of the state legislature in future biennia?
Yes, we put out a 3-year plan, and the biggest increase, I would say, is to provide the Medicaid match for as we roll on more of the Medicaid population. So eventually we'll be serving or offering the program to all families of newborns, and we know that half of those approximately are Medicaid supported. That's their insurance. So we would need the general fund to provide that Medicaid match. The the state level support and some of the other, the contracts would just need to be ongoing, but they would not expand.
Thank you.
That's it for the
Now,
questions?
those are the questions we've received.
Okay. We want to provide a little bit more time if there are any other questions that people might have.
And one thing that I would, if I can take just a second to point out, one of the questions we often receive is around how data is used in this program and how that is protected. So I did want to share just a little bit more since we have a few more minutes. Family Connects is a voluntary program. Families are offered the service, say yes to the service, and at the time of the service are provided another opportunity to consent to the treatment, consent to the visit. And any information that's gathered is then only shared back with community partners in an individualized way or even an aggregate way when the family has agreed to that is permissible from their perspective. And so one-to-one sharing back with their pediatrician, their maternity care provider, their family practice provider, another home visiting provider, or service provider in the community is really based on both the family's need and their desires for those services. So they will affirmatively consent to sharing individualized information. And our system, while documentation is maintained there, does allow for the nurse to be very specific about what pieces of information have been consented to share from the family. In aggregate, without identifiers, that information can be used to build reports that are useful in community decision making and actually are maintained and managed locally. And so they're not set to Duke for some level of reporting and sent back, but local administration of that information is the norm. And then that information can be used to help understand needs and strengths of families in the community, but also very specifically, nurses will conference weekly to talk about their cases. They will utilize the staff members that are actively working on community alignment to better position the nurses for success and the community partners for success, so ensuring that alignment is there. And one example we might pull from, or there are a couple of things. One of the things that happens in the nurse case conference is the ability to identify trends and need very quickly. So nurses are meeting weekly, talking about the cases they've seen, and being able to say, this is something I encountered, have you guys run into this yet? And not too long ago in Durham, we had that happen where nurses were reporting that they were having to spend a great deal of time and more frequency than they would have expected in correcting the way families were mixing formula for families that were using formula either exclusively or as part of the feeding for their infant. And then they were able to recognize in that conference that, in fact, there were some similarities in terms of the pediatric providers for those infants, and which led to an uncovering pretty quickly of an error in the electronic health record and the instructions that were being provided to families. So there was a new EHR in use. The instructions that were being provided to newborns were actually those for 6-month-old babies, and we were able to correct that really quickly with the pediatric providers being very appreciative of us bringing that to their attention. Other sort of community level indicators, so that's the very specific, working with one community provider to rectify. But another example in one of our communities early in their process, nurses brought back information from the family support matrix that identified that a fairly large ratio of families were borrowing car seats to leave the hospital. In order to leave the hospital, you had to have a car seat for safe transportation of your infant, but the family didn't own that car seat. They borrowed it from someone else and they had to give it back. So when the nurses were in the home talking with families about their ability to actually engage with these services and supports, how could they get there in a very rural community where public transportation wasn't available, families were indicating that they did not have safe transportation for their infant. And the community was able to use that information to put in place resources, identify dollars that could be used to purchase car seats that were then available at low or no cost to families with a referral from the Family Connects nurse. And so that was something that within the first 4 to 5 months of program operations, they identified the need, found resources, and were able to institute a program and service in the community. they also were able to sort of move upstream and look for ways prenatally to ensure families understood where they could get free or low-cost child safety equipment, both car seats and cribs. And so they use that information locally. So just wanted to share a little bit because I think that has been a concern in terms of how information is shared. And one of the things we did learn in our research was that 94% of the families in the randomized control trial that received the Family Connect visit and had that assessment done indicated some level of need that can be met by the nurse or longer-term community resources. And that continues to be the case with 94 or more percentage of families having something on that matrix where they needed support, which lets us know that having a baby is in fact a universally vulnerable time and points our policy in the direction of providing support to all families that then can be individualized in terms of longer term access to services. That was a long thing, but now do you have other questions?
We have a couple of additional questions.
Sure.
What is the estimated cost of the program? Is it the intent that costs will be covered entirely by billing, or is it expected that there will need to be some sort of local contribution other than the match?
So I can talk about the cost, and then I think one of the questions we have is whether in the reimbursement structure that's here in Oregon, what the gap might be in funding. Across the country, our experience tells us that in order to operate a full program with Family Connects, which includes both nurse home visitors, program support staff, community alignment staff, data systems, all of the things that go with that, that we are somewhere between $500 to $700, $600 to $800, depending on the cost of nursing services per birth in a community, so not per family served. And in most of our communities, they are using a blended funding stream that might include some reimbursement from health insurance, that may include local contribution from tax-based dollars or philanthropic dollars or other competitive grant applications. So we do anticipate in this planning year to both identify the cost that we anticipate in each of these early adopter communities, funding revenues that are available, funding streams that might be available to cover that cost, and what gaps there may still be.
And then along those same lines of funding, will there be any funding made available to local departments for planning?
Yes, so part of the 1921 budget, out of that community support bucket that I was talking about earlier, there will be some funding to provide support around convening, preparation, focus groups, interviews, training, so that the community can have both preparation of the community alignment process as well as preparing for the service delivery. So it's not a lot of money, but it's enough to kind of get things jump-started. One of the objectives of the community alignment process is really to get all the partners possible around the table and talking about who is doing what, how can we connect and create efficiencies, how can we leverage each other to resource the program. That's going to be the sustainability piece of this model. So while there is some funding to get it jump-started, the whole community alignment process will be focusing on that sustainable piece.
Regarding the data collection, will all of the documentation take place in Theo, or is there another form of documentation?
Well, there is another form of documentation, and we are investigating ways to interact with or ensure that there is very limited to no duplication of data entry for nurse home visitors or other program support staff. Thankfully, both Theo and our data system developed by Family Connect International have some opportunities for interoperability, and we have some time to develop both the initial structure and maybe the long-term vision for that.
Thank you.
Okay,
that's all of our
that's
questions.
all we have at the moment. Wow, we finished a little earlier than we had planned out, but that's fine. If there are any further questions that you think of later after you're just kind of mulling in your head a little bit, or through conversations that you might have with colleagues, please feel free to send them to the email address on the screen. oregon.uohv@state.or.us, and we will respond as timely as we possibly can. We do see one more question pop up.
Is this being recorded and will it be posted?
Yes, it is being recorded, and yes, it will be posted on our website, and we will send out the link to that website too. It's pretty static right now. It's not the website that we envisioned, and that we'll be developing as we implement our communication plan, but it is a landing spot where we will be able to post this webinar. And if you have colleagues that weren't able to make it to this offering, we are offering it again this afternoon from 3:30 to 5, correct? Okay. Anything else? All right, I would like to thank the presenters, Jordan Kennedy and Ashley Alvord, for their expertise, as well as our very mighty and able support team, Katie Cuspis and Derek Patterson. And we look forward to providing the next update in about a quarter's time. So thank you all very much and have a great day.